This conference will now be recorded.
So yes, today we are doing this April 2017 talk, the role of thrombophilia testing in women with adverse pregnancy outcomes. Okay, so actually this talk is very short. Means the talk is long, but they have included all the trials. So basically their question was whether to do this thrombophilia testing in women with RPL and other adverse outcomes like severe preeclampsia, stillbirths and all those. Okay, and there are no clear-cut guidelines in this subject. So it was basically this talk is full with different studies and trials. So I have avoided that. I have just included the take-home message from this talk, and so it's a very short discussion today. So yes. So what are these placenta-mediated pregnancy complications? So it is recurrent pregnancy loss, fetal growth restriction, stillbirth, severe preeclampsia, placental abruption. So they complicate up to 15% of pregnancies, and they have been associated with maternal genetic predisposition to thrombosis. So it is expressed by a positive thrombophilia test. So it can be either inherited thrombophilia or acquired thrombophilia. So this inherited thrombophilias are activated protein C resistance or factor V lead-in mutation, prothrombin gene mutation, antithrombin deficiency, protein C deficiency, protein S deficiency, and factor 13 mutation. So these are inherited thrombophilias. And acquired thrombophilias, they are mostly related to the APLA. So it is either lupus anticoagulant, beta-2 glycoprotein antibodies, or anticardiolipin antibodies. So what are the treatment available for these conditions? What are the treatment they are studied, actually not available or recommended, but what are the treatments which have been studied till now? These are either low dose aspirin, unfractioned heparin, or low molecular weight heparin. So now when you see this heparin, so heparin, this increases the effect of natural anticoagulant antithrombin, while aspirin inhibits platelet aggregation. So these are the basic two things which are given for this recurrent pregnancy loss or placenta related complications. So what happens with heparin is there are so many adverse effects, or there are so many disadvantages with use of this heparin. So basically this heparin needed to be given by subcutaneous injection. Either it should be given daily or twice daily, depending upon whether you are using prophylactic dose or therapeutic dose. Also, it is expensive, and there are some adverse effects with this low molecular. Actually, you know, with unfractioned heparin, there are significant adverse effects like heparin-induced osteopenia and heparin-induced thrombosis, allergic reactions. But there are some adverse effects they are associated with low molecular weight heparins also, but they are mostly minor, but they occur in approximately 40% of women. And what are these adverse effects are? It can be mild local skin reactions like pain, itching, swelling, or bruising, increased risk of bleeding, HIT, that is heparin-induced thrombocytopenia, osteopenia, osteoporotic fractures. And whenever you want to give any anesthesia, you have to adjust the dose and you have to adjust the time frame also. Otherwise, it may cause this bleeding inside this, either whenever you are giving spinal or epidural, it may cause bleeding. Now, when you are considering this thrombophilias and adverse pregnancy outcome, so any drug if you want to give, at least it should be effective, correct? And it should be documented in the trials. So exactly what happens with this thrombophilias and adverse pregnancy outcomes. So usually in asymptomatic patients also, it is found that there is a high prevalence of this thrombophilic disorders. Okay, these mild thrombophilic disorders, they have high prevalence in asymptomatic patients. So it is not that the patients having thrombophilia, they will always have this adverse pregnancy outcomes. It can be asymptomatic also. Then when they have studied, what they have found it, there is no strong correlation between the thrombophilias and pregnancy outcome. Whatever they have found out in some trials only, but they have found out some weak association between thrombophilia and pregnancy outcome. So it is not a consistent finding that thrombophilias are associated with adverse pregnancy outcomes. And if you find any inherited thrombophilias on testing also, it is not guaranteed that there is some intervention that will benefit it. Okay, so it is not that always any intervention will be beneficial in that thrombophilia also, even if it is associated with this thing adverse pregnancy outcome. So these are the basic some precluding factors for this thrombophilia testing. So now what the recent guidelines recommend regarding thrombophilia testing? So 2016 guidelines, they are produced by Anticoagulation Forum in USA. It recommends that thrombophilia testing should be only performed when the results will be used to improve or modify management. And when you consider this criteria, all pregnancy-related outcome, adverse outcome, pregnancy-related outcome, they do not fit in this criteria. So most of the time, this thrombophilia testing is not recommended. Okay, so this is the recent 2000 guideline, and even all European meta-analysis and Cochrane reviews, they also substantiate this finding that thrombophilia testing is not recommended even if there are adverse pregnancy outcomes. So whenever you consider adverse pregnancy outcome, they are divided into two. One is recurrent pregnancy loss and another is placenta related adverse outcomes. Okay. So when you think about recurrent pregnancy loss, so recurrent pregnancy loss according to ISHRI and according to GTG definition, it is 2 and 3. Okay. So still there is no consensus whether it is 2 or 3 more consecutive losses. But when you take 2, the prevalence is almost 5%. When you take 3 consecutive losses, 3 or more consecutive losses, prevalence of this RPL is 1%. Now, as there is lack of any effective intervention, depending upon the thrombophilia testing, okay? So, even if you find thrombophilia also, there is no any effective intervention that can be given. So there is no indication for routine testing of inherited thrombophilias. Now you remember, for RPL, apply is recommended, but routine testing for inherited thrombophilias. Inherited means antithrombin 3, protein C, protein S, and all those what I have told in inherited thrombophilia. So there is no indication that you should do routine testing of thrombophilia for recurrent pregnancy loss. I think I am clear for this. Yes, you should do APLA testing, but you should not do testing for inherited thrombophilias. Be clear on this here only, okay? Now, placenta-mediated pregnancy complications. As I told you, it is severe preeclampsia, fetal growth restriction, placental abruption, and stillbirth. Why they occur? Because inappropriate coagulation pathway activation and placental developmental dysfunction. So these are the reasons for these complications. So these complications, they can occur in isolation, but you can find significant overlap. So in more, usually you find severe preeclampsia along with abruption. You will find severe preeclampsia along with fetal growth restrictions. Stillbirth are also common with fetal growth restriction. So there is overlap with all these placenta mediated complications. Now, all these conditions, they carry a significant recurrence risk. Okay, so significant recurrence is there with all this. You know, with abruption, 1 abruption 4.4, with 2 abruption, it is 25%. So it is, there is always a significant recurrence risk with all these complications. And consequent of, there is scope that you should do different trials, which intervention can be effective. But still, there is a lack of clear association between stillbirth and maternal thrombophilia. But there are different guidelines, international guidelines. They still recommend to screen the woman for thrombophilias if there is a stillbirth. Still, there are some international guidelines those who still recommend. But the recent guidelines by Stillbirth Collaborative Research Network. Okay, so the recent guideline by Stillbirth Collaborative Research Network, they have concluded that routine testing for heritable, that is inherited thrombophilias, it should not be done as a cause of stillbirth. Okay, so for stillbirth cause, to rule out any stillbirth cause, inherited thrombophilia testing should not be done. Here again, the exception comes with acquired thrombophilias with APLA syndrome. But yes, inherited thrombophilia should not be done either for recurrent pregnancy loss nor for any placenta mediated complications. Now, with this placental complication, always there is some histopathological abnormalities of the placenta, like decidual vasculopathy, thrombosis in vessels in decidua basalis, placental infarcts, maternal floor infarction, fetal thrombotic vasculopathy, vasculitis, or chronic villitis. So there is different combinations. They are these histopathological complications. They are found with these placental complications. So again, which placental features are associated with which complication, and whether they are associated with separate thrombophilias, it is still not properly studied. Okay, so it is again debatable whether if you find any placental. Now it is routinely stated that you should do the placental histopathology for stillbirth and all these things. So even if you find some histological problems with placental lesions, still it is debatable whether you should do thrombophilia testing depending on that. Okay, so because there is no proven established intervention also, and there is no proven correlation also. Now, regarding acquired thrombophilia or APLA syndrome. So, APLA, that is antiphospholipid syndrome, is defined as clinical manifestation that include either thrombosis or fetal loss or pregnancy morbidity in patients with positive antiphospholipid serology. What do you mean by that? Presence of either lupus anticoagulant, anticardiolipin antibodies, or beta-2 glycoprotein antibodies on at least 2 occasions 12 weeks apart. So it is not only one occasion, but you have to prove it on 2 occasions. Okay, so you have to prove it on the basis of blood test and along with this relation of this fetal outcome, adverse fetal outcome. Now there is another entity known as catastrophic antiphospholipid syndrome. It is a life-threatening disease and it has almost 50% mortality. It complicates less than 1% of total APLA syndrome, and it is characterized by onset of rapidly progressive and widespread thrombotic microangiopathy and by multi-organ failure. So catastrophic antiphospholipid syndrome is an entity, sub-entity of this APLA syndrome, and the mortality here is 50%, but it comprises less than 1% of total APLA. So whenever you find any adverse pregnancy outcome or APLA, how should be the subsequent pregnancy care? So as I told you, it is a TLC, that is tender loving care. That is the most commonly basis of all these RPL. That is emotional and mental health support, increased ultrasound surveillance, frequent visits, and timely delivery. These are the mainstay of treatment unless you find out any specific cause and treatment for that. Treatment with LMWH in women with inheritable thrombophilia is not recommended. High dose aspirin can be administered like 150 milligram. According to new guidelines, it should be 150 milligram. It administered ideally at night time, and it should be commenced before 16 weeks for women at risk of preeclampsia or fetal growth restriction. Additional thromboprophylaxis with low molecular weight heparin, it might be indicated in women with positive APLA syndrome antibodies and a history of either catastrophic antiphospholipid syndrome or venous thromboembolism. So these all you should know. And the basic thing of this TOG is inheritable thrombophilia testing is not recommended either for recurrent pregnancy loss or for adverse pregnancy outcome. So this TOG is finally very short, and take home message is only. Okay, this is the take home message talk. Remember well. So coming to the question of this talk, type in your chat box. What is now generally considered an indication for performing thrombophilia test in a woman who is presented 8 weeks of gestation routine? Okay, my connection was lost. Yes, most of you have given the correct answer. It is E. When the result will be used to improve or modify management. Second question. What is the estimated mortality risk associated with catastrophic antiphospholipid syndrome? Yes. Very good. It's 50%. Answer is E. So this is for today's.